I'm going to go ahead and get started with the introduction. It is my distinct pleasure to introduce Dr. Monique Chaaya, Professor of Epidemiology and Population Health at the American University of Beirut. Dr. Chaaya earned her PhD from the Johns Hopkins University in mental hygiene. Previously, she had earned her MPH and her BS in environmental health and epidemiology and biostatistics from the American University of Beirut. She served for 6 years as the chair of the Epidemiology and Population Health Department and played a major role in developing the proposal for a PhD in epidemiology program and revising the MPH and MS programs in epidemiology and population health. For the last 6 years, she's been involved in coordinating a training program to build research capacity of junior medical clinical researchers at the King Abdullah International Medical Research Center. Dr. Chaaya's research focuses on mental health and tobacco control. She's conducted cross-sectional and longitudinal studies on the mental health of vulnerable populations, including pregnant women, prisoners of war, and displaced older adults in underprivileged communities. Her current work is in aging and mental health with an emphasis on understanding dementia and caregiving. She's published her research in many journals, including Journal of Geriatric Psychiatry, Aging and Mental Health, Aging and Society, many others, and her work has been funded by NIH, the Lebanese Council for Scientific Research, Pfizer, the Mellon Foundation, and other organizations. Monique is, I thought, just midway through her sabbatical visit with us, but I think she only has one more week here, and she's very interested in starting collaborative projects with researchers here. So if you haven't yet had the opportunity to get on her schedule, I would urge you to do it as soon as possible. She's just great. And I'm excited to hear her presentation today, which is Uncovering Burden of Dementia in Lebanon. What next?
Okay, thank you. Okay, thank you, Dr. Hooker, for the presentation. I'd like to really thank also Dr. Nieto and Dr. Hooker for accommodating me during my short research leave at OSU. And I'd like also to thank some of the faculty members at OSU have been very generous accommodating me and their schedule to discuss potential collaboration. Particularly, I'd like to thank Dylan Mendez and Rob Stowski and others, many others, and I will have a chance also to talk to Dr. Aldwin. It's been really a pleasure being here. I love the campus. It's a beautiful town, Corvallis, and I hope to come back soon. So I'm going to I'll tell you where I'm coming from, so my hometown and my home university. So it's to understand the context where I'm coming from, why study dementia, and then the result of the dementia prevalence study in terms of the burden on the elderly and the caregivers. I've built a cohort of older adults that I will be talking a little bit about, and what next. So where I'm coming from, starting with the American University of Beirut in Lebanon, the Faculty of Health Sciences and Lebanon. This is AUB is on the shore of the Mediterranean Sea. It's one of the very few green spots in Lebanon. It's pretty much in an urban area. This is actually Beirut, and this is the campus that you see. It's really beautiful. It extends over 61 acres land, like to 50,000 square meters. It has also another so this is a rural place where people train on education and research and agriculture sciences. It's also a beautiful area in the rural Bekaa Valley, also extending over like 247 acres of land. And people actually learn how to grow stuff. They do research on animals, but also they have fun. So AUB is was founded by American missionaries in 1866. Last year we had our 150th anniversary, with a motto that they may have life and have it abundantly. So these missionaries they established something called the Syrian Protestant College that after 20 years became American University of Beirut. So the American University of Beirut is like 1,200 instructional faculty with almost 8,000 student grad and undergrad, 130 programs, and since 2002 we became accredited by the U.S. Middle State Commission on Higher Education. So all our programs actually have to be approved. We have a board of trustees. It goes through all the approval process and have to be approved by the New York State of Education Department, with 6 faculties/schools, and I'm in the Faculty of Health Sciences. So the Faculty of Health Science is also very interesting because this is the first independent public health school in the region, in the Arab region. So far, the public health has been taken by the Faculty of Medicine. So it's been like a department in the Faculty of Medicine. We're the first independent school. Again, we celebrated our 60th anniversary 3 years ago. And we are the only CEF accredited graduate program. So because we're not a school yet, because we don't have a PhD program, but we are accredited by CEF. Again, also since 2002, and we are only program accredited by CEF outside the Americas. So in the Arab world, in Asia and Africa, we're the only program accredited by CEF. So the faculty has that include the 5 disciplines of public health. We have one common MPH program that has several concentration in health promotion and health management and in epidemiology biostat, 2 MSs in environmental sciences EPI. We have a joint program with the Faculty of Medicine, which is called MS Sharp, which is a clinical research. And we have another division of health profession that offers BS program in collaboration with the Faculty of Medicine and the American University Beirut Medical Center. We have a big referral medical center where we train our 102 doctors every year. Recently, we established an MS in Public Health Nutrition with the Faculty of Agriculture and Food Sciences. And only 2 days ago, we got the news that the PhD in EPI proposal that we worked over like 3 years got approved by the New York State Education Department. And I'm looking forward to at least collaborate on that program and have really strong ties with the faculty of the College of Public Health here at OSU. So that was really a great achievement for us. This is the FHS model. This is something that I got from my dean, Dr. Iman Nwahid, who shared some of his slides with me, 2-3 slides. So just to tell you that we have like 360-degree model, where we have in the middle our teaching, learning, particularly the department and the graduate program of public health. And we have 3 centers, a center for research on population and health, a center for public health practice, and a center for knowledge, from knowledge to policy translation. And there's a lot of synergy between teaching and these centers that will actually enhance the learning of the students. So a lot of service classes, a lot of activities, voluntary activity by students in these centers. And actually, this is all to better the public health. The faculty has a diverse research agenda. We're not very much focused, we're not disease specific, we're more focused on population-based research. So you have like group that focus on youth health, women's health, elderly's health, and now refugees' health. So we have a big group working now, conflict and health or refugees' health. And we have created, which is really nice, we worked multidisciplinary, so it's like across department and with other faculty as well at AUB. And we have created 2 very well-known now groups. One of them is the regional reproductive health working group that includes scholars from Egypt, Jordan, Lebanon, Morocco, Oman, occupied Palestine, Sudan, Syria, Tunisia, Turkey, UK, US, Yemen. This has been established since the 1980s. They've been meeting every year. They've been getting funding, and it's a very nice regional collaboration. In addition to another research group that's an AUB tobacco control research group with very strong connection with University. Our most recent work has been on water pipe, hookah, name it. We have actually established a consortium on water pipe, and we have our 2nd international conference in November. And this includes people with multidisciplinary specialty, medicine, epi, bio, health promotion, health policy, psychology, sociology, oncology, management. I didn't put everything. So all working towards tobacco control measures. And actually, it's that group that advocated for a very strong tobacco control law that was established 3-4 years ago, which was not very well implemented. Faculty of Health Science also had good collaboration and networking outside AUB, outside the wall of AUB. The important one currently is their work on the commission on the Lancet Commission on Syria, which is health and conflict, and looking at the effect of bombarding all these health facilities in conflict. We're working also with establishing a global master with Costa Rica, which is Earth University in Costa Rica, to also have a master's and global masters in health. In addition to also establishing networks outside Lebanon with the region. So where I'm coming from, this is where I'm coming from, this red spot. This red spot is as big as Connecticut, actually. And thank you, Karen. She asked me, how big is Lebanon? How large is Lebanon? So I tried to see which state actually is. So this is Lebanon with an area of 4,000 miles and a population of almost 4 million, very similar to Connecticut. It's an upper middle income country, and its GDP is 7,914. And we have an estimated 13% who are 60 years and above. It's Western Asia, so this is the Mediterranean Sea, and this is Western Asia. Behind us, there's Syria, Palestine, Israel, and the sea. And this is the small one. This is Cyprus. This is the island of Cyprus. It takes 20 minutes to get there. So this is how I got here. Okay, this is a 7,000 mile. It's been 1 day and a half of traveling, Beirut, Paris, Seattle, Portland, and 2 hours to Corvallis. So now on top of the 4 million, we have another 1 million, almost 1 million or 1.5 million of refugees, Syrian refugees. Actually, the doors were open to welcome any Syrian refugees. But now is 1 in 4 people in Lebanon is a Syrian refugees. And actually, we host almost 10% of the total refugees. And if you want to see really the picture, this is the refugee. This is not a very updated one, but this tells you a little bit about the refugee situation. So all in pink are internally displaced within Syria. Syria is very big, times the size of Lebanon. But Lebanon now has, this is according to this, but we're a little bit more. We have 1 million in a country of 4,000 miles or 10,000 square kilometers, compared to Turkey, which is we're like 1% of the total area of Turkey, and Turkey has 1,600,000. And usually these are in transition. I mean, they go to Turkey to go somewhere else. Jordan is many less, 600,000, and Jordan, most of the refugees have been placed in formal settlement and in tents, while our Syrian refugees have been either in informal settlement or integrated in places. So they might have formal apartment, an unfinished building, etc. So actually, we have the largest burden of the Syrian refugee. We've been doing well, but this is just to tell you how much pressure on our healthcare system is there. So with this, I'd like to show you that, tell you that Lebanon is a beautiful country. It's this is the shore. So the shoreline is 130 miles. We have 2 range of mountains, the western and the eastern one. It's a valleys, the mountains, and the shore, and it has a very unique topography, and you can be skiing and swimming the same day. It's so the largest width in the country is 80 kilometers. So you can imagine it. So this is Lebanon. So what's about its health profile? We have a life expectancy reported by WHO in 2015 to be 74, 76. I've heard recently before I came here that one of the estimates for female now is 80. So the life expectancy is getting really higher. I don't think this is surprising. We have 60% of all our deaths is non-communicable diseases, and most of the deaths due to NCDs are related to cardiovascular diseases. And the top 2 leading causes of DALYs, which are disability-adjusted life years, this is the global burden of disease measure, are ischemic heart disease and stroke. So again, this is also a little bit related to my interest in dementia, because these are CVD are one of the major risks for dementia, particularly vascular dementia. The healthcare system is similar to the US. Most of it is reliant on the private sector, but the Ministry of Public Health finances 40% of health expenditure, and 12% are by private, insurance. So why a study on dementia in Lebanon? Let's start with dementia globally. Globally, it's really very frightening, and it's not surprising, because with the increase in survival, I mean, people live longer, and living longer doesn't mean living healthier. So living longer with more chronic diseases, and one of those chronic diseases that really carry a lot of disability. These are infographics from the World Alzheimer Report. This is the latest World Alzheimer Report of 2015, which states that we will have in 2050 131 million demented person. And actually, every 20 years, we have like a 20, maybe, I don't know, it will double. I mean, the number of demented will double every 20 years. 68% of these would be living in developing countries. Now, 58% of the demented are in developing countries, but it will go up to 68%. This is the 18th largest economy because it really bears a lot of cost, not only on the formal services, because not all demented end up in nursing home, but it's also as informal services. So it's really one of the largest economy. And if we look at the map of the world, so also it shows that 9 million, this is in the Americas, currently demented, but we have 22 million in Asia. So this is really a high burden that people have to look carefully at. So what about the MENA region? So I come from the Middle East and North Africa. This is actually a region that's been, that we talk about like South Africa, South Asia. So the Middle East and North Africa, this is one of the global burden of disease region, has all these countries, I think 23 countries. Most of them are Arabic-speaking countries, except for Somalia, Djibouti, Afghanistan, and Pakistan, and Iran, which is the Persian. Otherwise, these are Arab countries, and these are called the AMRO region, the Eastern Mediterranean region. So we have two regions that are very much integrated. So in the MENA region, if we look at this, one, it is actually experiencing this increase in the proportion of elderly because of demographic transition, because of higher life expectancy, with few exceptions. And I cannot tell you that that Yemen has that's high life expectancy, because people do die very early. And the number of, so the number of people expected in 2010, we had 1 million demented. This is expected to increase to 2.6 million in 17 years. So it's really, in 13 years, sorry. So it's a 125% increase, which is the second fastest rate of increase in the world. I think we're also, the fastest increase also is in the Latin world. Yet research in dementia is scarce. We don't have people working on dementia. It's maybe because there are other priorities, and now it's the war, the conflict, maybe the other mental problem, but also partly because we don't have validated screening. We didn't have validated few years ago screening and diagnostic instrument. We don't have many psychiatrists. We don't have neurologists who are interested in this. And this actually led to inaccurate estimate in the prevalence. We don't actually know the magnitude of that disease. We don't know the burden of that disease, because it's only when you know the burden that government can allocate resources. If they don't know the burden, they don't know the number, why should they invest in services, and why should they meet the need of these demented? So we need accurate prevalences to assess the burden, raise awareness, and definitely at least make an impact on this social policy that ultimately would affect the people living with dementia and caregiver. In addition to, of course, whenever we know the prevalence, incidence, risk factor, we are able at least to build some effective intervention, especially in the early stages of dementia, because we don't have treatment. Because it's been shown that if you screen early and you get these people early on medication, at least their the course of the disease would be sometimes better. Okay, so this is the standardized prevalence by the global burden of disease. Also, just to show you that our region has the highest. It's in the upper range of the global prevalence. So the prevalence is a very short, very narrow prevalence from 5.6 to 7.4. The one that was published is like more than 8%. Again, is that accurate? Is that something that we can trust? This is based on very few studies, but nevertheless, it tells us something, that it is something that could be of concern to government. So what's the case in Lebanon, one of the MENA region? One, again, similar to other countries, we don't have much research on that. The only two research that were done on dementia particularly were done by a geriatric psychiatrist who in 2007 looked at those in the nursing home, and she checked their how many of them were demented, and this is 60% who are demented in nursing home. Is that something about magnitude? Definitely not. This is service-based proportion of people with dementia. Another geriatrician also, as part of her PhD, did a study in rural Lebanon, and then she found the prevalence of 20%. Again, that 20%, both use MMSE, which is the mini mental state examination, which is not very valid, especially on population with high illiteracy. So based on this, again, these two are not something that we can rely upon, and therefore, and we don't have validated tool, and that's why I did a study. So this study, we got a grant from NIH in 2011. It's a pilot study. It's an R21. So this is the American ambassador. Of course, she was there because she's the NIH. This is the donor. And my collaborator were from Denmark, from the Danish Research Center from Copenhagen. This is Q Funk. Her husband is the Danish. And then our provost, myself, a neurologist, a geriatric psychiatrist, neuroepidemiologist, and myself as an epidemiologist who's interested in aging. So what were the aims of that grant? One is to assess the feasibility of establishing a cohort of older adults. We wanted to reach 2,500. NIH gave us a grant to start with 500 elderly to see whether we will be able actually to establish that cohort and to validate tools. So validating one tool, which is diagnostic tool, and two other screening tools for dementia, and to generate preliminary data about prevalence and collect data on risk factor, access to care, morbidity, caregiver burden, and other. So I'm going to talk about the validation, just few results, not to overburden you with numbers, and then with the burden and the caregiver. And I think I'm okay on time. So for the validation, we took 244 participants who were 65 and above, 144 normal cognitive status, and 100 with mild or moderate dementia. They were recruited from community and from hospital-based clinic. We ascertained the cases by neurologists and by looking at the medical record. Two MPH graduates independently translated to Arabic and back translated to English. And we met with the community and with elderly representatives just to make sure that actually whatever we're asking are culturally relevant and the language is actually appropriate. So, so this is the field work of the validation. The people who collected the data were fellows in neurology, fellow in geriatric, family medicine resident, and one MPH graduate. So we went and took to these people. These were in the suburb. And we used several cognitive assessments. One of them is that diagnostic assessment. It's a one-stage assessment that's very good and applicable and relevant, and cross-section study. Because cross-section study, you go once, you can't go another time. So we do one-stage data collection. This 1066 DRG is, let me tell you where the name comes from. So this is it's a group that was established by a researcher, Martin Prince, geriatric psychiatrist from King's College London. This is because he noticed that most of the research is not done in the developing countries. So 10% of the research is only done in the developing, while 60% of people demented, they live in the developing countries. So this is the 1066 research group. The tools are four instruments that are the community screening instrument for dementia, CSID, the 10-word list recall, geriatric mental state. It's like to diagnose any kind of mental disorder, depression, anxiety. So at least these are to rule out other diagnoses. And we had an informant interview. So what's this particular diagnostic package is to collect data from the elderly and from his or her informant. So it's a dyad. And we had an algorithm with a regression and weights for every component of this diagnostic tool. And we come up with a status that's either binary outcome, demented, not demented. It's particularly for mild and moderate dementia, because severe demented we are not able to look, and we are not able to look at. So we also did validate two screening tools. Also, they are very sensitive to culture, language, and education. One of them is the Rowland Universal Dementia Scale, which is a 6-item, which has good psychometric properties. We'll see now. Excuse me. And another one, which is an informant questionnaire on cognitive decline in the elderly IQ code. So this is a nice tool. It's a 10-item tool, 10 or 20, sorry, I forgot. But we ask if an informant, have you seen changes in the elderly for the past 10 years? So, and based on a cutoff of 3.4, this elderly will have cognitive decline or not. Again, this is screening, not diagnostic. So this is just a summary of the properties of that 1066 DRG, just to note that it has 92% sensitivity, I need my glasses, and more than 90% specificity, high positive predictive value, and very low false positive with no formal education or for people who are depressed. So this is really a tool that has excellent psychometrics.
Good question.
Yes?
What's the gold standard here?
This is the neurologist who went and who looked at all the documents to ascertain whether somebody is demented or not. And we had the control from the community. So we had 100 control and 144 demented, or vice versa. So if you take each item or each component alone, it does not have the same psychometric property as when you take all the 4 components. So with the 4 components, with that algorithm that was developed by this guy, Martin Prince, you have very excellent psychometric properties. Okay, so it has excellent property for those, especially, and this is applicable for those with high illiteracy. And our elderly have high illiteracy rate, but now with new generation, I don't think you will find many illiterate once they get to the 36. At least those currently living right now. And the validation for the 2 screening tests, again, as a screening, we had good psychometric property. I would say acceptable psychometric process, which is a screening test, Rowland Universal Dementia Scale, and the IQ code, which is an informant type of scale. And we have published, actually now, we have 4 articles on the validation. So the prevalence study, we validated, so once we had the tools, we went into the prevalence study where we recruited males and females who are above 65 years of age from the capital city of Beirut and from 2 small districts or counties in a big governorate or in a big state or whatever you want to call it. And then we selected randomly 1 older adult from a household, and we asked this older adult to identify an informant he or she knows him or her very well. So to give us data about any change in cognition. So we had 502 elderly informant dyads, of which 466 in the consent form said we're willing to be revisited in 3 years' time, that I've done this year actually. So we have a little bit more females, and we asked them questionnaires, household risk factor questionnaire, an informant questionnaire, the validated tool. We had also neurological exam, like we put a rope and we asked them to walk on a rope. We took anthropometric measures, so on and so forth, and it was like a 2-hour interview. So this is Lebanon again. So we took data from Beirut. This is the tip Beirut, and from 2 districts. And this is the way that we selected was a proportional sampling based on the size of these districts and the population distribution. Okay, so the aims were to assess the prevalence and to investigate association between demographics, socioeconomic status factors, CVD risk factors, and dementia. So these are the demographic characteristic and socioeconomic measure that we have chosen: age, gender, marital status, education, occupation, and income. And income, we did not collect the actual income because we know that people do not tell us about the real income. So we ask about income sufficiency, whether their income is sufficient to meet their basic need. And the risk factor, we had hypertension, diabetes, obesity, smoking, heart problem, physical activity. The hypertension and diabetes, we asked them whether they have been ever diagnosed or told by a doctor that they have hypertension. But at the same time, we took their blood pressure twice to make sure that they have a controlled blood pressure. We asked them about their tobacco use, lifetime, cigar, water pipe, current smoking and intensity, and when they got their diagnosis about hypertension. Obesity, we measured their measuring weight and height, and physical activity. Of course, with a cross-sectional study, always some of the measures are very soft, and but at least we made sure that at least we pick up the best indicators. So the result, the overall crude prevalence was 7.4%, and the standardized was 9%. So standardized using the Western Europe population. So this is pretty in line with whatever we've seen from the Alzheimer report, and it is really in the higher range, higher level of this range of in the MENA region. And if we look at the by age group, again, this is also expected that we start with 3% at the age group 65 to 69, and then it goes up to 20.6. So the dotted line is for the Middle East and North Africa region. The reason for having maybe less here is because we didn't have enough people in the 85 and above. They were really very few, and I don't consider this percentage to be very much accurate. But again, we know that it's an exponential increase, and it's scary after the age of 80. So if we live to be at age 80, more than 1/4 of us would end up having dementia. Sorry, this is not good, but anyway, or other things. So this is how I learned it actually at Hopkins. And we had a higher proportion of prevalence among female compared to male. And when we look quickly, I didn't go into all the analysis, unadjusted ORs, etc. But I want to show you what are the predictor, and we're using the best model, the most parsimonious and with the best predictive value. So we had age that in the 75 compared to 64, we have 4 times the chance of having dementia compared to those in the 64. And for the 85 is 7 times that compared to 64. Again, both significant. Income sufficiency, after controlling for gender, marital status, education, and all other variables that are cited here, also those who reported insufficient income had a higher odds of having dementia compared to those who reported sufficient income. And with the hypertension, not the controlled, but the non-controlled, we have an odds of 6 times. So it's 6 times higher odds if people have uncontrolled compared to people not having hypertension to have dementia. So first of all, at least this provides, at least we can consider with all the rigor of the way we have selected our measures and selected our study population, is that this is a good, accurate of dementia, and this is actually worrisome. 9% is actually worrisome in a population of 4 million, which has currently more than 400,000 elderly. So we're talking about a good number that needs services. We'd like to definitely understand the reason. I cannot start predicting what stop uncontrolled or go. I think poor blood pressure can have many reasons. It could be lack of adherence, maybe based of low awareness. Sometimes people stop their medication because they feel better. So is that it? Is it poor access to medication? So what is it? So we need to understand it better. But definitely any intervention for proper management of CVD risk factor, particularly hypertension, would definitely pay off. And we've seen in the literature some interventions that have been actually reduced dementia. And I would like to, between brackets, say that the US is witnessing a decrease in the incidence of dementia. And this has been actually, the reason for this has been like the decrease in tobacco control, smoking, CVD risk factor, etc. It's similar when the number of admission to ER because of heart attack for non-smoker decreased when you have proper tobacco control. So I think all the CVD risk factor and the control of the CVD risk factor is actually leading to a decrease in incidence. The association of insufficient income with dementia is something to reflect upon. I don't know if this is just a measure of social disparities, because it's not explained by all other factors in the model. So it's not like because you don't have insufficient income that you are. So it's not explained by the CVD factor that are in the model or socio-demographic. And I think further analysis will be performed to understand this association. And of course, these data are to be used to show the policymaker to maybe start thinking about intervention, and more analysis are underway anyway. But more importantly, with all this dementia is really the impact on the caregiver. And I've had really the pleasure of talking to people about caregiving, and I've really learned a lot. And there's a lot to work on when I go back, taking my data, analyzing them, and probably collaborate with colleagues here on caregiving. Based on that data, on my data of the 502, so we identified caregiver. Not all of them are caregiver. The 502, most of them are healthy, good, independent. But we picked up the caregiver. We compared their mental health to non-caregiver. We compared the mental health of different types of caregiver based on the level of care provided, because some caregiver, they only are in organizational care. Some of them partially contribute. So we look also at the difference and the burden between the different level of care, in addition to looking at what are related with the burden of care among caregivers. So what do we know about caring for older adults? I mean, it's not actually polarized. It's either family care or formal services, but these are the two most common form of caregiving, either family care, which is mostly in the developing, and low middle income countries and Arab region. I know that it exists here, so I didn't know how to put it. And more in the developed world is we have the formal services. But we also have something as the retirement home, which is not nursing home, which is not totally institutionalization. It's retirement that people maybe decide, and I've heard also what's the new policy here or whatever, a new the new plans for the retirement. And you have something called the green farms. This is something new in Denmark, where you have a town like Corvallis, which is very much done in a way to accommodate demented. They don't even use the money. They use something which is like the monopoly money type of money. And then it makes it so easy for demented and their family to live in that they call it a green farm town or something. So, but nevertheless, if we're talking about the formal services, we know that, at least from literature, that in developing we have a much higher institutionalization rate than ours, maybe because we don't have many institutions and nursing home. But definitely in low middle income country, in places where family is really matters, in places where in Lebanon, a person who's 30 or 40 years old, single, would be in with his family, living with his family, until he or she gets married. So I think that the obligation is understanding, and not implicitly, that everyone who has elder parents or relative needs to take care for them. So there's a lot of social, cultural, and religious obligation. And so even in the religion also, they talk about caring for your parents. Be careful, don't leave your parents. So the family caregiver burden, it's a physical, psychological, and emotional. It's a strain on the person. And it's been found out that this care burden is associated with a female. So more female are more likely to have more burden related to caregiving. Low educational level increase the care burden. If you're living with the elderly, whatever the disability is, more hours involved in the care, depression, social isolation of the care recipient, financial stress, and lack of choice, so we don't have any other alternative, is associated with caregiving. Dementia caregivers also there's another component of caregiving, himself or herself having these disturbances or symptoms. It's not easy. It's not like somebody with diabetes or somebody who has a stroke. But it's also this issue when the demented has depression, aggression, and sleep disturbances as well. So this really becomes a much higher burden on the caregiver that's associated with stress of the caregiver, it's depression, anxiety, and mood disorders. So if you want to see the carer mental health, it's affected by care recipient. So is it demented, non-demented, has cognitive issues or not, has functional impairment or not, the type of care, more hours, more tasks, longer duration, and carer profile. Is it the spouse, older, the female, the low social support, so on and so forth. So Similar, why we're collecting also, where we're looking at that, we don't have enough data. I know that we have much more here, more abundant, not in our part of the world, and not definitely no studies in the Arab region, at least to my knowledge, I haven't seen any, and in Lebanon specifically, we don't have. So again, those 502 that we collected data on, we identified 64 caregivers. Some of them had hands-on care, organizational or partial, and these were 80% were main caregivers. We had two tools to assess their burden, something called the self-reporting questionnaire, which measures psychological distress. Another one is the ZARID burden interview, which was actually constructed for dementia caregiver, and it measures strain or burnout associated with dealing with dementia. So the 64 are not all demented because we only had 7% demented. We had only 37 demented. So the 64 have different types of disability, including dementia. So the caregiver is a female. 75% of the caregiver are female. Remember, our sample are like more than a little bit half female. We have 75% female in the caregivers. On average, the age of the caregiver is 47 years of age. Younger females, because usually the female is the daughter. In most of the cases now, it's the daughter, the spouse or the daughter. So it's in her 40s. Caregiver had significantly higher scores on psychological distress. And we have used appropriate statistical tests for this because this is small sample. We use non-parametric tests. And if we look at now, I said I want to compare according to the level of stress. So those who had hands-on have higher score both on the SRQ and on the ZARID, which is the burden, and much higher and significantly higher than organizational care and partial care. So people who spend more time, who help the elderly, who talks to organize, are much more, have more burnout, they're higher strain. And when we try to understand and look at association of some of the factor with having psychological distress among the 64 caregiver, very interesting results. So we got having a source of income. So if you have a source of income, you are less likely to be strained. So the odds are protective. So you are okay. Maybe you can afford even this is controlling for having a helper actually at home. So just having a source of income reduces or is associated with lower odds. Caring for an elderly with anxiety is associated with a higher level. Okay, I know that the numbers are small, but it's a good preliminary analysis of this data. And caring for an elderly with dementia, although associated with an odds of 2, but this was not significant. So it's mostly anxiety, which is more this. So family caregiver, just to emphasize that they are important stakeholder in the continuum of care of disabled elderly, but particularly for demented elderly as well. And attending to their psychological well-being and even social well-being, I think, is important for that continuity of care, especially that the preference, I know, for the elderly is to remain in the family. Demented like to be in a familiar place. And that's why usually they get more aggressive when you take them out of their place that's very familiar. So if we can at least assist those family caregiver to have a good life, to have enough time for themselves, and to have less strain in dealing with the elderly. Of course, this needs to come with financial support and psychosocial support to safeguard their continued ability to provide care. Having been here, I think there's a lot to do to understand the culture, the familism, things about caregiver, what type of support is mostly related to strain. So I haven't done my job and really looking at all the data. There's really a lot to look at. And I need to also understand maybe the coping mechanism, because some caregivers are doing actually well and others are not. So understanding, maybe doing some qualitative interviews, a mixed method approach to understand well how they're experiencing this caregiving and learn in order to build better intervention. So to care for those who once cared for us is one of the highest honor. This is always, we think about this. So currently, I just finished data collection of the cohort. So I was able to reach 345 out of those who consented for a follow-up, they were 476. So 72% agreed to be followed up, or I collected data on 345 because 120 who died, but we know why they died from which cause they died for. So we collected data on them. The field work is completed, and what we collected data on this time is incidence of dementia, mortality, institutionalization, hospitalization, dementia comorbidity, change in behavior risk factor, more on mental health of a caregiver, and the burden of care. Now we're cleaning the data and hoping to start So there was a lot of challenges with the cohort. Very few cohorts have been done in Lebanon or in my part of the world. We had issue with the IRB, the Institutional Review Board, to see how to go back to these people. Let's say one of the very interesting issue was in the previous consent, informed consent, there was, do you consent to be recontacted? Recontacted. So, and it was, of course, translated in Arabic. So for them, recontacted meaning calling on the phone. And we had their number. But recontacted does not mean only calling on the phone. So when we called, they changed their number. The number were wrong. And we had to go through like 8 months of IRB to convince them that we can go back to these people. I have their address. So they said, go back, knock on the door and say, can I recontact you? So just because of this coercion, because they don't want us to just show up on the door and say, you said you can be followed up, let's follow you up. So there were a lot of ethical issues that we had to deal with. Of course, loss to follow up is an issue. And this is why now I've gotten a grant, small grant, to do an expansion of the cohort in a rural area. But I'm not taking like a very random sample of the whole rural area, but taking villages, because it's much easier than to trace the person rather than going to all villages. So at least to confine those cohort people within a certain geographic location. There was a lot of change in informant or caregivers. So this is something that we needed to accommodate for. Not to mention that some of the elderly had their physical and mental health deteriorated. Some of them were not able to talk to, and one of them actually had left. So where to now? So where to is, we are doing a lot of now analysis on cognitive reserve and dementia. So any activity that they have been in their midlife, they've been involved in, like board games, knowing languages, being part of community organization, reading newspaper, etc. So we're trying to come up. We didn't have any tool for cognitive reserve, but we had several indicators that we are putting together to create an index for cognitive reserve. We looked at cognitive decline, the decline dementia, with social capital and social activities in midlife, and also we had very nice results, significant and expected results. But okay, I think I did not change. So and I'm looking for nurturing collaborative work in the US, and of course, so this is I did not, and also in the region, because in the region I'm trying to find funding. In the GCC they have funding, and we're trying our best to get more funding other than the NIH. So we're exploring some NIH funding on caregiver. And ultimately, I think as a public health person, I don't want only to publish. I'd like really to look at intervention that could be maybe sustainable, that could be and scaled up. Is it a priority? I think it's a priority for my research. So this is just to acknowledge that this is the study that I've done is was funded by NIH, NIA, and the Fogarty International Center. This is my research group. And sorry, this was supposed to be. So where to? Collaborative work with my colleague from OSU, secondary analysis of existing data on caregiver, and so this should have showed this one. This is my new research team from nursing, internal medicine. Also, we have one from biochemistry and molecular genetic, and an RA. So, I mean, oops. Okay, and thank you. That's it.
Some time for questions. So Monique, you want to?
Yes.
Thank you so much for this. I think it's so important for us all to understand the global impact of dementia. I have a question regarding the economic burden.
Yeah.
Do you have a way of estimating financial impact that dementia has on individuals and their families?
I think we can do that, but we have to collect data. And that's why I came to Janho. So I don't know if he's here. I thought that as a health economist, he could at least help me. I thought that his work. But I'm sure that with the help of a health economist, we can always estimate some of the informal support, because we know that some of these caregivers, for example, we're talking about the informal support, some of them have left their work, some of them are absent from their work. And we know how much they use health services. Actually, I do have data on health utilization of services. Of course, most of them have many unmet needs. They don't all of them go. But I mean, there is some estimate. And I think this is one also. I should have put it what next, because I think you're right. Policymaker would love to see this, because when we were advocating for the tobacco control law, what they were actually impressed is by how much the Ministry of Public Health was paying for NCDs and surgery, which are smoking diseases. So they said, no, I put something on prevention rather than paying all that amount in tertiary care. So I think if they see a number, they will definitely, a number of the magnitude is important. And soon I will be talking to some people at the Ministry of Public Health. But the dollar sign is definitely much more important. And that's why we have, if I may, this K2P center, which is knowledge to translation. So we're thinking of doing some kind of a policy brief. So that policy brief can maybe at least start up a discussion with policymaker about putting priority for dementia. Yes?
You remember, maybe you said female prevalence is higher than male, right?
Yes, but when we did the regression...
Due to the female living longer than male?
Yes, exactly, survival.
How about the age-adjusted prevalence?
Yes, the age adjusted is 9%. But when I did the regression with the age inside and the gender was no longer significant. So adjusting for age, gender was no more significant, and which is actually consistent. So gender and the bivariate analyses, we found much higher. But when we adjust for age, it was no longer significant. Yes?
Thanks again for a great presentation. Your findings with cardiovascular disease risk factors and tobacco are striking and common. Do you anticipate any lines going forward where you look at cardiovascular disease prevention and control as a primary intervention for dementia?
Yes, I have thought about that, but I don't feel that strongly yet to think about what kind of intervention to think, but definitely, yes, especially with hypertension. Yeah. I don't want to overuse the data at this point in time. I'm very cautious but this uncontrolled hypertension is an issue. And we're looking at midlife hypertension again, not hypertension currently. And I think now with the cohort data, that will give me even better understanding of this. But yes, intervention, targeting cardiovascular risk factor is really should be the top priority. Or at least I would advise or recommend that. Thank you. Yes, Rob.
This was really, really wonderful, really interesting data. One of the things that struck me when you were presenting the results about just kind of the predictive validity of your measures and such for the prevalence study, that the memory measure actually had one of the lowest positive predictive values, and typically we think of dementia and such, estic presentation is definitely one of the earliest indicators, and it's definitely one of the most prevalent complaints. That given that it was maybe one of the potentially weaker components here, whether you think the phenotype of what's being picked up here is a little bit different, whether the measures maybe operate somewhat differently, or that you're capturing people who are maybe cognitively impaired but not necessarily demented, or maybe in a mild cognitive impairment state where they are probable for developing dementia, but intervention could still be possible to mitigate.
Okay, let me start from so we removed the MCI. So mild cognitive impairment were actually selected out, excluded. This is on the validation study. Now, with respect to your question on the memory not having the highest predictive value, I mean, dementia is now defined as the a major neurocognitive disorder. There's only decline in cognition and decline in one of the cognitive domain. But it doesn't specifically say, let's say, that memory is one of those domains. So it could be one of the phenotype there. And remember that we're talking about dementia, not a specific type of dementia. So maybe if it was the Alzheimer type, maybe it would have, the memory would have been maybe different than the vascular type. But I don't know, I didn't reflect a lot on that, but we were so much impressed or happy with the high predictive value of the whole diagnostic. And we don't know actually the weights inside. It's a very much, he protected very well his algorithm, Dr. Martin Press, until recently we're able to, dissect it. So, but you're right, it could be another phenotype, but I don't think this necessarily the loss of memory is the first thing. It could be sometimes an orientation issue. So they go and they forgot. So it's much more orientation rather than memory. It's about sometimes the language. So you start some of you just skip some of the names, whatever. So I think it's a lot of domain and not necessarily one particular domain of cognition. Yes, okay.
I was intrigued by the observation of 10 for dealing with anxiety disorders as opposed to the dementia itself. And I'm wondering if you had any interesting insights on that.
Okay, now anxiety is actually a diagnosed anxiety. So it's because it's used the GMS, which is the Geriatric Mental State Exam, which actually has also an algorithm. It's based on an algorithm. This is anxiety. So we're talking about maybe, so the demented, not all demented have, they might be calm, especially those at the beginning. So they would be calm, they don't have these behavioral symptoms, they're not agitated. Anxiety, which means nervous, agitated. So this could be this behavioral symptom. Actually now it's a whole area of research that NIH are actually putting calls for to look at these behavioral symptoms of demented that could be really very difficult to. So the issue of the dementia, we have only 37. So the 10 is actually high, but the P is not like close to 0.5 to say this is loss of power. So we didn't have enough power to find a relationship, but it's something to look at. But again, the 37, maybe it's the 37. Maybe it's the anxiety that's much more because it's a behavioral symptom rather than only being demented. And again, the demented that we have diagnosed, some of them are mild, some of them are moderate. And we were able to talk to them. And this means that actually there's still people who can maybe talk to you, etc. So at this level, maybe the anxiety is much more, could be an issue. But then it's not about only dementia, it's about anxiety in general. So any elderly who has anxiety, irrespective of his dementia status, is actually more strain on the caregiver. So it could be an anxious diabetic person, an anxious person with stroke. So it's not about actually dementia, it's about anxiety, any other things being controlled for.
There's been so much interesting discussion, and I think Monique would probably be willing to stay for a few minutes if anybody has a burning question that they'd like to ask her. Let's thank her again.
Okay, thank you for having me.